I would like to express my gratitude to the EAN and the organizers of this virtual Congress. The outline of my presentation is along its learning objectives. I will talk about the classification of status epilepticus and the EEG in diagnosing non-convulsive status epilepticus, the Salzburg criteria. Then I will use cases to illustrate the key points. In 2015, a task force of the International League Against Epilepsy issued a new definition and classification of status epilepticus. Using semiology, one can classify status epilepticus in two major groups, with prominent motor symptoms and without prominent motor symptoms. Now, in the first group, with obvious overt convulsions, one can diagnose status epilepticus without EEG. However, when it comes to non-convulsive status epilepticus, EEG is a must. EEG is needed for the diagnosis of non-convulsive status epilepticus. Now, having said that, I would like to emphasize that these two groups are not dichotomically separated. In reality, often there is a fluctuation, a dynamic interchange between these two groups. So a patient can start with a convulsive status epilepticus, then go into a long non-convulsive status epilepticus, come back and have seizures and back to the non-convulsive status epilepticus. So please keep in mind this fluctuation. There is a wide variety of ictal EEG patterns, so no surprise, there's also a wide variety of status epilepticus EEG patterns. There have been several previous attempts to develop EEG criteria for non-convulsive status epilepticus, and in 2013, at the fourth Status Epilepticus Colloquium in Salzburg, a panel of experts had a consensus discussion, and we have developed the criteria that nowadays are called as the Salzburg criteria for non-convulsive status epilepticus. Then we also issued a follow-up paper in which we explained in detail how to apply these criteria in clinical practice. So let me guide you through the Salzburg EEG criteria for non-convulsive status epilepticus. Let me start by emphasizing that the starting point of this algorithm is a clinical suspicion of non-convulsive status epilepticus, so you need clinical symptoms there for at least 10 minutes, according to the new ILA definition. So if you have this clinical suspicion, then you do an EEG. And then, if you record epileptiform discharges with a frequency over 2.5 Hertz, then you can already fulfill the first criterion and you can diagnose non-convulsive status epilepticus. Now, very importantly, you shouldn't just measure one wavelength and take the reciprocal as the frequency, or just count the number of the cycles during 1 second. These are misleading because although we call them rhythmic, these activities are actually quasi-rhythmic, so the frequency can change within a period. So just picking 1 second or 1 cycle can be misleading. So what we advise is that you take 10 seconds period, count the number of cycles, and you use that to express the frequency. So for example, in this EEG, here you can see 10 seconds, and then you count the number of spike and waves, and this is 31 spike and waves per 10 seconds, so it fulfills the criteria. Okay, but what if the frequency is under 2.5 Hertz, or if you don't see at all epileptiform discharges, yet you can see continuous quasi-rhythmic delta theta activity. And in this case, you need secondary criteria. And in this gray box here, I will show you the secondary criteria. The first one is the typical spatiotemporal evolution. And if you work in an epilepsy monitoring unit and you see lots of seizures in patients who are not on the ICU, you are very familiar with this pattern. Is the evolution in time and space of an ictal. I usually tell my students that an ictal rhythm is not a dead rhythm, it's not a monomorphic rhythm, it has its own life. So it changes in time. You can see it starts with a low amplitude, high frequency activity here on the left side. And now let's follow this in time. You can see that gradually the form changes. The amplitude increases, the frequency goes down. So this is the evolution in time. But then you can also see an evolution in space. So it starts on the left side and then it gradually propagates to the neighboring electrodes or it goes over to the right side. So this is the evolution in space. Now, subtle clinical ictal phenomena during EEG pattern. What can these subtle seizures be? Well, these are discrete phenomena like twitches in the eyelids, face, jaw, extremities, or the trunk. There can be head or eye deviation or peculiar automatisms. And if you are familiar in cardiology with the electromechanical dissociation, then you would easily understand this. It's the same just for the brain. Now, unfortunately, these subtle phenomena can be caused by other etiologies, not just the status epilepticus. They can be, for example, because of a lesion in the brainstem or the medication that the patients get in the eye. So here, for example, you can see the discrete perioral twitches. And if they are time locked to EEG changes, then it's a status. Now you can see discrete twitches in the left thumb. And this can go on for hours. But then if you wait long enough, they can go over into an overt seizure. So if we wait a little bit, yes, here you can see that it goes over to a manifest seizure and then go back to a non-convulsive subtle state. Now, another secondary criterion is to test the modulation of EEG and the clinical phenomena by intravenous anti-epileptic drugs. This is not for therapy. This is to assess its modulation. For example, in this case, you can see epileptiform discharges continuously, yet their frequency is not high enough to say that it satisfies the criteria. Now, after IV anti-epileptic drug, you can see both that the epileptiform discharges disappear and the background activity improves. Now, if there is also a clinical improvement, then you call it a definite non-convulsive status epilepticus. Yet, if you can't see an improvement, then you call it a possible non-convulsive status epilepticus. When the clinical improvement is not obvious, the patient is sleeping, yet you can see an improvement in the EEG. Now, another important aspect is this fluctuation. So you remember when it was an evolution, then there was a gradual change in frequency in the same direction. So for example, 2, 2.5, 3, 3.5, and so on. But what if this change is back and forth like a ping pong, 2 hertz, 2.5 hertz, back to 2 hertz, again 2.5 hertz. Then you don't call it an evolution, you call it a fluctuation. And then you call it a possible non-convulsive status epilepticus. Now there are some important additional aspects I have to mention here. How long do you need to see these patterns fulfilling the criteria? Well, according to the Salzburg consensus criterion, it's 10 seconds. Now, let me emphasize, I'm not saying that 10 seconds of symptoms is enough to have non-convulsive status epilepticus. No. You need the clinical signs there for at least 10 minutes, and the whole EEG is abnormal. But the climax of these changes, where the changes, EEG changes, are so abnormal that they fulfill the criteria, that's the 10 seconds. Now, because children with epileptic encephalopathy have also in the interictal stage, they have horribly abnormal EEG, and we don't want to treat them unnecessarily. We added some additional criteria for the patients with epileptic encephalopathy. So in this case, you need an increase in prominence or frequency of these EEG abnormalities when compared to the baseline. Unfortunately, we often have EEGs recorded previously to compare with. and an observable change in the clinical state, which can be, for example, told you by the caregivers. Or the other additional criterion for the children with epileptic encephalopathy is the improvement of clinical features and EEG features with intravenous anti-epileptic drug administration. So you simply make this branch compulsory. Now you might ask, how accurate is this? Does it work in all different types of non-convulsive status epilepticus patients? And please keep in mind that none of the previously published criteria has ever been clinically validated before. So we did a multi-center clinical validation study on the Salzburg criteria, and we found an almost perfect, substantial, almost perfect inter-rater agreement. And the sensitivity was pretty high, close to 100%. We only missed one patient with non-convulsive status epilepticus, yet specificity was not perfect. So you can see it's just close to 90%. So we had some false positives, but we rather wanted to have a high sensitivity, of course, at the cost of a little bit lower specificity. Now we did subgroup analysis, and the criteria, because they cover so broadly, they worked well also in the different etiological subgroups. So we concluded that the Salzburg criteria for non-convulsive status epilepticus have high diagnostic accuracy, an excellent inter-rater agreement, and they are suitable for implementation in clinical practice. Now, let's look at some cases to see how we can apply the Salzburg criteria for non-convulsive status epilepticus. So the first case is a 72-year-old male. He had a thalamic hemorrhage and the right hemiparesis. 3 days after the admission, we observed altered consciousness. Glasgow Coma scale was 10. The CT showed no new lesion when these changes occurred. So then we did the EEG, and what we've seen in the EEG are these lateralized periodic discharges, LPDs, here on the left frontotemporal region. Now you can see on this slide that the frequency is between 0.75 and 1 Hz. And then all of a sudden it goes higher up to 1.5 Hz, and then 2 Hz, then back to 1, again 2 Hz. So it fluctuates between 1 and 2 Hz. So let's look at the Salzburg criteria. Well, it's this case with fluctuation, and this is a possible non-convulsive status epilepticus. The second case is a 78-year-old female. 2 years prior to admission, she had an ischemic stroke in the right middle cerebral artery, and she had a palsy on the left side. 1 day prior to admission, she became agitated, she developed loss of consciousness, and this was intermixed with periods of 30-90 seconds with discrete jerks in the left upper arm. The CT did not show any new lesion. So on this EEG, you also can see some polygraphic channels. So these channels in green at the bottom, they are EMG, surface electromyography channels. So then you can see in the C4 channel, in the right central area, you can see slow waves. Now each slow wave is followed by a burst in the EMG electrodes. Now let me show you also the video. So here you can see these subtle jerks in the left arm, time locked to the delta waves in the right center area. So how does it look on the Salzburg flowchart? Well, these are subtle clinical ictophenomena, time locked to the EEG abnormalities. So this is a non-convulsive status. The third case is a 67-year-old male. He had a cardiac arrest, and we recorded this EEG 3 days after the return of spontaneous circulation. Now what you can see is diffuse polymorphic delta activity, mainly in the anterior leads. And then here you can see marked when we applied nociceptive stimulation, you can see there is also reactivity. None of the branches, none of the Salzburg criteria is fulfilled. So in this case, this EEG does not fulfill the Salzburg criteria. Case 4 is a 71-year-old male. He had cardiac arrest, and 3 days after the return of spontaneous circulation, the Glasgow Coma scale was 8, and we observed occasionally periods with discrete jerks. The EEG shows these generalized periodic discharges with a high frequency. So there are 27 such discharges in a 10 seconds period. So this again fulfills the Salzburg criteria because we've seen discharges at a frequency over 2.5 Hertz. The fifth case is an 82-year-old female. She had cardiac arrest, and then 3 days after return of spontaneous circulation, we have observed myoclonic jerks. We administered propofol, the jerks stopped, and this is what you can see when the patient is on propofol. You can see there is no jerks. You would see it as an artifact on the ECG channel, but no jerks. And then after reading the propofol, you can see this EEG, still this periodic occurrence of these complexes, but the amplitude is higher, more rich in fast. Let's see what the video looks like. Yeah, so now you can see that this is correlated with myoclonic jerks after reading of the propofol. So how does this fulfill the Salzburg criteria? Again, you can see this subtle clinical ictal phenomena during the abnormal EEG patterns. Thank you for your attention. So I guess this is time for answering questions. And this is my question to the technical team. So am I back live?
Yes, you are.
Yes. Thank you. So one question so far, I'm asked what is the exact cause of non-convulsive status epilepticus? Well, there are many causes of non-convulsive status epilepticus. It can be an acute symptomatic, it can be based on a brain lesion or a metabolic disturbance, it can be a remote cause, it can be based on an electroclinical syndrome. So what you see most often, well, it depends on the type of your hospital you are working in. I have two affiliations at the university hospital where we have lots of acute cases. Probably one of the most common causes is the post-anoxic that Nicola will talk about, but we see quite often also in patients with cerebrovascular lesions and autoimmune encephalitis. And then at my other affiliation, the Danish Epilepsy Center, the most often cause I can see is in electroclinical syndromes. So there is a very wide variety of causes of non-convulsive status epilepticus. So any further questions? Yeah. Yeah, so Olga is asking which anti-epileptic drug do you recommend for children? I assume that your question is asking what I would use for testing the EEG and clinical modulation for diagnosing non-convulsive status epilepticus? Well, we start with benzodiazepines, and then depending also again, depending on the etiology, we might even proceed to a second-line drug if the modulation on the EEG and the clinical improvement is not obvious. For example, we can proceed giving intravenous valproate. But again, this depends on the diagnosis. Yeah, and then Mikhail is asking whether the GPDs, the generalized periodic discharges with identical intervals, non-convulsive status epilepticus, even with high frequency. Yeah, so if these discharges are really close to each other, and if their frequency is over 2.5 hertz, then they fulfill the criteria. Now, the truth is that at such high frequencies, it's almost a continuous discharge. So yeah, in this case, but again, it's the frequency that matters according to our criterion. But if there are GPDs with frequency over 2.5 hertz, then we would consider it non-convulsive status epilepticus, just as I've showed you in one of these cases. So, okay, I have another question here. Yeah, again, this is very similar, which anti-epileptic drug? I assume this is addressing again the Salzburg criteria. Again, we start with benzos, and then depending on the etiology, so we would, and if the response is not obvious, then we would go on with valproate or levetiracetam. Yeah, I don't see. Yeah, Oliver, one more question. How do you disentangle non-convulsive status epilepticus and severe toxic metabolic encephalopathies? Well, in severe toxic metabolic encephalopathies, you would see usually high amplitude, diffuse polymorphic delta activity, and then you can see triphasic waves. But again, none of these would satisfy our criteria for EEG criteria for non-convulsive status epilepticus. So again, EEG is really helpful in these cases to disentangle between the non-convulsive status epilepticus, which usually would fulfill the Salzburg criteria, and the toxic metabolic encephalopathies, where you would see a different picture, mainly polymorphic delta activity and triphasic. Okay, let me see whether further questions arrived. Yeah, so the last case not presented was a non-convulsive status epilepticus, or rather convulsive status epilepticus given the not sure subtle myoclonic jerks. Well, again, if the subtle myoclonic jerks are time locked to the EEG discharges, then and only then you consider them as fulfilling the Salzburg criteria. Now, if you see subtle phenomena, but not time locked to the EEG, then they do not fulfill the criteria. Okay, so then Dmitry is asking whether generalized periodic discharges are less than 2.5 hertz. Is it non-convulsive status epilepticus, or should we follow other criteria? Yeah, exactly. So if it's under 2.5 hertz, then on its own, it does not fulfill the first criterion. So you need at least one secondary criteria. For example, as you correctly wrote, if you have some subtle jerks, time locked to them, or you see modulation, so an improvement in EEG. It's rarely you would see an improvement in clinical status in these patients, but if you see an improvement in the EEG in these patients, then you can classify it as a possible non-convulsive status epilepticus. Please remember that improvement of EEG is not just disappearance of these discharges. it's also that the background activity is improving. Yeah, how often is the complete recovery from non-convulsive status epilepticus? Yeah, well, this is a complex question because this depends on the etiology. Now, if the non-convulsive status epilepticus is in a post-anoxic patient, as Nicola will talk about soon, then the prognosis is not so good. It's quite bad, although it's not bad in all patients. So up to 10% of them would survive without major sequelae. But if the non-convulsive status epilepticus is, for example, in a patient with an electroclinical syndrome, like a patient with juvenile myoclonic epilepsy who just forgot to take his or her medication, then the improvement is really rapid and the prognosis is good. So the recovery, well, this depends on the etiology that is behind the non-convulsive status epilepticus. Well, the question is about propofol. This is quite often used as a third-line therapy in our system. It's because you can taper it quite rapidly, so you can assess then the effect of you can assess the EEG after a rapid withdrawal of the propofol. Then Paula is asking, how long do you need pattern burst suppression for treatment of status? Yeah, well, there's no clear consensus on it. So all the experts would agree that what you want is to stop the seizures, but then how deep the suppression of the EEG activity should be, that varies from center to center. So we titrate the third line drugs, the anesthetic drugs, so that we achieve a burst suppression. So we try to go for 8 seconds versus 5 seconds. I'm not saying this is the best way that that exists, but at least that's the practice in our center. Now I think it is time to proceed to the next presentation. The second talk